Welcome. With this session, we'll start a discussion of surgical management of glaucoma, and in this session, we'll be discussing about trabeculectomy. In the next session, we'll discuss about complications of trabeculectomy. Surgical therapy of glaucoma reduces intraocular pressure by reducing resistance to aqueous outflow, either by creating an alternate pathway for aqueous outflow or by improving outflow through the physiologic pathway. Incisional surgeries create alternate pathway, and they include trabeculectomy and tube shunt devices, but they are associated with significant rate of complications such as hypotonic cataract formation and endophthalmitis. Techniques which improve outflow through the physiologic pathway include angle surgeries such as trabeculotomy and goniotomy, as well as procedures called minimally invasive glaucoma surgeries. And this group of surgeries are associated with a lower incidence of these adverse effects. Trabeculectomy is the most common form of filtration surgery performed for glaucoma, and it is still considered the gold standard primary filtration surgery. Trabeculectomy is an incisional surgery in which a fistula is created which bypasses the trabecular meshwork, the Schlemm's canal, and the collecting channels to drain aqueous humor directly from the anterior chamber to the subconjunctival space. And from the subconjunctival space, the aqueous is then absorbed in either the conjunctival vessels or the aqueous passes through the conjunctiva into the tear film. The fistula is created or guarded under a partial thickness scleral flap to reduce the risk of post-operative hypotony. So this diagram shows the fistula of a trabeculectomy transferring aqueous directly from the anterior chamber to the subconjunctival space, and the fistula itself is guarded under a partial thickness scleral flap. The inner opening of the fistula is called the internal ostium, and adjacent to the internal ostium we also see a peripheral iridectomy is done so that the peripheral iris does not occlude this internal ostium of the fistula. This diagram represents a front view of a post-trabeculectomy eye, showing the partial thickness scleral flap through the margins of which the aqueous drains out into the subconjunctival space. Some aqueous is also said to drain through the scleral flap itself into the subconjunctival space, and from the subconjunctival space the aqueous is drained either into the conjunctival vessels or through the conjunctiva into the tear film. So the trabeculectomy fistula can be considered as a series of incisions and planes among which only the conjunctiva should heal with scarring in order to prevent Bleb leaks, which we will be discussing in the next session. And the other portions of the fistula such as the internal ostium, the undersurface and the margins of the scleral flap, the subconjunctival space, as well as the iridectomy should remain free from healing response and should not scar, and this is very important for the trabeculectomy to successfully lower the intraocular pressure in the long term. So the surgical technique is aimed at achieving a balance between effective IOP lowering by increasing aqueous outflow while at the same time avoiding complications due to excessive aqueous outflow such as hypotony and endophthalmitis. Success of trabeculectomy is usually defined as achieving an intraocular pressure of less than 21 mm of mercury and or achieving 30% reduction from baseline intraocular pressure with or without additional anti-glaucoma medications. And trabeculectomy has been reported to be successful in 80% of patients with the most common forms of open-angle glaucoma such as primary open-angle glaucoma, pseudoexfoliation syndrome, and pigmentary glaucoma, and also in patients with primary angle closure glaucoma, but not in patients who have had an attack of acute angle closure. So this photograph shows a patient with a diffuse bleb following a trabeculectomy, and as we will be discussing, this is one form of functioning bleb. Trabeculectomy is indicated when there is visual field progression despite maximal medical and or laser therapy, when medical therapy is not effective either because of the medicines failing to control intraocular pressure or because of poor compliance from the patient or because of poor tolerance of the medications by the patient or because of occurrence of side effects, when there is advanced visual field loss even if the intraocular pressure is low and is unresponsive to further medical treatment, or conversely when the intraocular pressure is very high even if significant visual field loss or progression is not present. Relative contraindications to trabeculectomy include very poor visual potential, anterior segment neovascularization, uveitis, conjunctival scarring, scleral thinning, prior trabeculectomy, and for patients who appear unable to comply with post-operative instructions. Any intraocular surgery is relatively contraindicated in an eye with very poor visual potential because any intraocular procedure in any eye induces a risk of sympathetic ophthalmia, however small, with no benefit so far as vision is concerned in eyes with very poor visual potential. As we will be discussing further, in these indications, a tube shunt surgery may be preferred over a trabeculectomy. Trabeculectomy has a lower success rate in patients with glaucomas other than primary open-angle glaucoma, primary angle closure glaucoma, pseudoexfoliation syndrome, and pigment dispersion syndrome in younger patients, in whom a prior trabeculectomy has failed either in the same eye or in the contralateral eye, in patients who have undergone a cataract extraction or any other intraocular procedure through a conjunctival incision, and in patients with diabetes mellitus. When surgery has been planned and before performing the surgery, certain preoperative considerations are important prior to trabeculectomy. First is site selection, and a superior location is selected which gives maximum coverage by the upper eyelid, and it has been seen that interpalpebral and inferior blebs have a high risk of endophthalmitis. When selecting a site for trabeculectomy, areas which need to be avoided include those with scleral thinning, such as may occur in patients with myopia, prior scleritis, prior surgery such as scleral tunnel, cataract surgery, and scleral buckling, areas with conjunctival scarring such as may occur following surgery and in patients with cicatrizing conjunctivitis, areas with peripheral anterior synechia, areas adjacent to a prior iridotomy because of the risk of vitreous prolapse, and in post-keratoplasty eyes, the superior scleral area nearest to the graft host interface should be avoided. Apart from selection of the site, other preoperative considerations for trabeculectomy include increased risk of infection in patients with dry eye, blepharitis, and lagophthalmos, peroperative control of uveitis, neovascularization, and herpes simplex keratitis, and patient-related factors such as usage of anticoagulants and or antiplatelet agents, and if the patient is uncooperative, non-compliant, or has unrealistic expectations. Immediate preoperatively, the intraocular pressure and the blood pressure should be checked, and they should be under control to reduce the risk of intraoperative suprachoroidal hemorrhage. The intraocular pressure should be less than 30 millimeters of mercury, and many prefer to give mannitol infusion preoperatively. Also, following injection of the local anesthetic, the globe should be soft prior to starting the surgery. Trabeculectomy is usually done under local anesthesia followed by digital massage to reduce intraocular pressure till the eye is soft to palpation, and a partial thickness traction suture is passed through the superior cornea and the globe rotated inferiorly for better exposure of the superior sclera. We'll be discussing the steps of the surgery diagrammatically before we see an actual surgical video, and the diagrams are oriented with respect to surgeon's view. Following the placement of the corneal traction suture, which will not be shown in the diagrams, the conjunctiva tenon capsule is incised, and we have two options. Either we can make a fornix based flap or a limbus based flap. So this figure shows a fornix based flap with the flap attached to the fornix, and this figure shows a limbus based flap with the flap attached to the limbus. For a fornix based flap, a 6 to 7 mm long incision is made along the superior limbus, disinserting the conjunctiva tenons capsule from the superior limbus. And a fornix based flap is said to provide better exposure for the surgery and result in a diffuse bleb, which is an ideal outcome and which we will discuss later. For a limbus based flap, the conjunctival tenon incision is made parallel to and 8 to 10 mm behind the superior limbus. And in comparison to a fornix based flap, a limbus based flap is said to have a lower incidence of early bleb leak. Presently, fornix based flaps are preferred by most surgeons, and it is also the preferred option when a previous surgery interfered with the conjunctiva near the limbus, because in this situation, if we make a limbus based flap, when we continue the subconjunctival dissection under the conjunctival flap anteriorly, the conjunctival flap may disinsert at the scar tissue near the limbus. A broad area of subconjunctival space is dissected with blunt-tipped scissors, and the scissors are used to cut tissues in the subconjunctival space only when required. And for deflecting the conjunctival flap, the tenon should be grasped when possible, else the conjunctiva should be grasped with non-toothed forceps, which reduces the incidence of conjunctival tearing. Then wet-filled cautery is applied to the planned area of the scleral flap, and the traction sutures are usually released at this step. Then the partial thickness scleral flap is made, and a careful construction of the scleral flap is important both for the success of the procedure and to avoid post-operative complications. The scleral flap can be rectangular, triangular or trapezoidal in shape, and we will demonstrate with a triangular flap. The scleral flap should be 4 mm wide along and just posterior to the limbus and centered at 12 o'clock position whenever possible to prevent bleb exposure and dysesthesias. The bleb should be 2 to 2.5 mm in length posteriorly from the limbus and ideally have a 50% depth within the sclera. Partial thickness scleral incisions are made along the margins of the planned scleral flap, and the scleral tunnel dissection is carried anteriorly towards the cornea past the anterior end of the limbal vessels till at least 1 mm of bluish grey zone of the peripheral cornea is visible under the flap. Then a paracentesis is made to provide access to the anterior chamber to inject fluid or viscoelastic as and when required, and it is usually made in the temporal clear cornea aiming towards 6 o'clock position. The paracentesis should be made slowly and carefully in eyes with high intraocular pressure. The fistula which is next made should be centered under the scleral flap and should be adequately covered by the scleral flap on all sides. To prepare the fistula, the anterior chamber is first entered with a blade near the anterior edge of the scleral flap. This initial entry is then extended to excise a corneoscleral block 1 mm by 1 mm in dimension. This extension can be made either with scissors or with a Kelly decimates membrane punch. To excise corneoscleral block with scissors, the blade which originally entered into the anterior chamber is used to extend the entry 0.5 mm on either side. Then 1 mm radial cuts are made extending superiorly from the two ends of this initial incision. This direction is with respect to the anatomical position of the eye. Then this corneoscleral block is reflected anteriorly and superiorly and excised along the scleral spur. When a Kelly decimates membrane punch is used as shown here in this photograph, the tip of the punch is introduced through the initial entry made with the blade, and then the punch is used to remove tissue from the posterior lip of this initial entry. Sclerostomies should be limited to this dimension, as larger sclerostomies can induce more irregular astigmatism. Peripheral iridectomy is made following excision of the corneoscleral block, and as we have mentioned earlier, this iridectomy prevents occlusion of the internal ostium of the fistula by the peripheral iris. To make the peripheral iridectomy through the fistula, a portion of the peripheral iris is grasped with a forceps held radially, the iris pulled out externally and then snipped with angle venous scissors held circumferentially. The iridectomy should be larger than the sclerostomy opening or the internal ostium, and many are of the opinion that peripheral iridectomy is not required in an eye with uneventful pseudophakia with the intraocular lens in the capsular bag, either done previously or being done in the same sitting as a combined phacoemulsification and trabeculectomy procedure. The scleral flap should be securely closed with non-absorbable 10-0 nylon sutures with a cutting needle which has sharp edges, and this is in contrast to suturing of the conjunctival flap, which should be done with a non-cutting or a vascular needle which has a round cross-section. A tighter closure of the scleral flap with these sutures are required when antifibrotics are simultaneously used, and one can make one of these sutures a releasable one as shown here in this diagram to allow post-operative suture removal at the slit lamp to improve aqueous outflow without reopening of the conjunctiva or without using laser for suture lysis. So the releasable suturing technique shown in this diagram has the suture passing through the stroma of the cornea in this portion, through the stroma of the cornea and sclera in this portion, and through the stroma of the sclera in this portion. The remaining portions of the same suture are external. A single not multiple throw suture is made for the scleral flap with these two external portions. This external portion is trimmed once this knot is tied and placed to securely close this portion of the sclera. Then with the help of this loop, the entire suture may be removed post-operatively, thus releasing this knot to increase aqueous outflow. After closure of the scleral flap and before closure of the conjunctival flap, flow through the scleral flap margin should be checked by injecting fluid through the paracentesis. Ideally, the anterior chamber should become deep and globe should become slightly tight before fluid begins to flow externally from the margins of the scleral flap. If there is excessive flow of fluid through the scleral flap margins and the anterior chamber collapses, the scleral flap sutures are loose and they need to be retightened. And if the anterior chamber deepens and the eye becomes firm to hard, the scleral flap sutures are tighter than required and they need to be loosened. Fluorescent can be used to check exit of fluid from the scleral flap margins. Then the conjunctiva and the tenon are closed, and this closure should be watertight to prevent post-operative bleb leak, and this is very important to remember. And the closure is usually done with a 8-0 absorbable polyglactin or vicryl suture on a vascular non-cutting needle, which reduces the chances of conjunctival tearing during conjunctival suturing. Fornix-based flaps are closed with a running suture along the limbus or with two wing sutures as shown in this diagram. And limbus-based flaps are closed with a running suture in one or two layers for the conjunctiva and the tenons layers separately. Following closure of the conjunctiva, fluid is again injected through the paracentesis, and this should result in deepening of the anterior chamber with sustained elevation of the bleb, which indicates both adequate patency of the fistula and adequate conjunctival closure. Here again, fluorescent may be used to check for any leaks through the conjunctival margin or through the surface of the bleb. Here we will see a video in which trabeculectomy is being done with a Fornix-based conjunctival flap. This video will also show application of antifibrotics, which we will be discussing subsequently in this session, and also placement of a releasable suture, which we have already discussed. So first, the conjunctival incision has been made along the limbus and conjunctival dissection is being made in the subconjunctival space. Light cautery is done to occlude the blood vessels on the sclera, and then with a blade, the margins of the scleral flap are being delineated. The thickness should be 50% of the depth of the sclera. Then by using scleral tunneling technique, the scleral flap is lifted till the peripheral cornea is reached. The antifibrotics are then applied in the subconjunctival space before entering the intraocular environment, because the antifibrotics are toxic in the intraocular environment. After removing the antifibrotics, the subconjunctival space is thoroughly washed. Here a Kelly punch is used to excise the corneoscleral block, and the iridectomy is done. The scleral flap sutures are placed. And one releasable suture is placed with the technique we have just discussed. So this is the loop with which the suture can be removed post-operatively. And the conjunctiva is closed. Following surgery, topical antibiotics are advised for 1 to 2 weeks and topical steroids are advised 6 to 8 times daily with a gradual taper over the next 3 months. Topical cycloplegics are required in patients with crystalline lens angle closure glaucoma and in patients having hypotony post-operatively. The patient should be checked one day following surgery, following which the patient is reviewed every week for the next 3 weeks and then every alternate week for another 2 months. The most important factor which ensures long-term success is a formed bleb in the early post-operative period, and this is very important to remember. A formed bleb in the early post-operative period prevents fibrosis from occurring between the conjunctival tissue and the episcleral tissue. Bleb inflammation in the early post-operative period with engorged conjunctival vessels and subconjunctival hemorrhage predict increased risk of fibrosis subsequently, leading to failure of the bleb in controlling intraocular pressure. Blebs can be classified as functional, which lower intraocular pressure successfully, and non-functional, which fail to lower intraocular pressure effectively. In a functional bleb, as seen here in this photograph, the conjunctiva overlying the bleb should be avascular but not ischemic, with microcysts in the epithelium of the conjunctiva. And such a bleb with an avascular conjunctiva and microcysts in the epithelium can be either diffuse as seen in this photograph or circumscribed. Non-functional blebs which fail to control intraocular pressure can be either a low or a flat bleb or encapsulated bleb, which is also known as a tenon cyst. In a low or a flat bleb, there is no space between the conjunctiva and the episclera, and these blebs are usually vascular and do not have microcysts in the conjunctival epithelium. An encapsulated bleb, also known as tenon cyst, is a highly elevated smooth grown bleb as seen here in this photograph, having large vessels in the conjunctiva overlying the bleb with intervening avascular spaces and with no microcysts in the conjunctival epithelium. And on moving the conjunctiva over a tenon cyst, a deeper fibrovascular layer can be detected underlying the conjunctiva, and this fibrovascular layer is the actual site of obstruction to aqueous outflow. A tenon cyst usually develops within the first 2 months following surgery. Then we come to adjuncts, which may be used during a trabeculectomy procedure, and among adjuncts we have antifibrotics, Ologen implant and express shunt. Antifibrotic agents, also called antimetabolites, inhibit post-operative healing response, and this healing response is the major obstacle to aqueous outflow through a trabeculectomy and thus in the long-term success of glaucoma surgery in achieving an intraocular pressure in the low teens, that is around 12 millimeters of mercury. So by inhibiting healing response, antimetabolites improve aqueous outflow and thus increase success rate of trabeculectomy in controlling intraocular pressure, particularly in situations with a high risk of failure, such as in an eye with a prior failed trabeculectomy. On the other hand, by improving aqueous outflow, antifibrotic agents or antimetabolites increase the risk of hypotony and endophthalmitis occurring following trabeculectomy. Two antimetabolite agents are usually used: 5-fluorouracil and mitomycin C. 5-fluorouracil inhibits DNA synthesis and thus prevent fibroblast proliferation, and 5-fluorouracil is known to be highly toxic to the corneal epithelium. Mitomycin C is obtained from a fungus and it cross-links DNA, preventing proliferation of fibroblasts and blood vessels. Mitomycin C is known to be highly toxic to the corneal endothelium, and as compared to 5-fluorouracil, mitomycin C is more prone to cause post-operative hypotony, which may be caused both by increased filtration and aqueous hyposecretion, which occurs when ciliary body is exposed to mitomycin C following inadvertent intraocular penetration of mitomycin C. Antimetabolites can be applied intraoperatively, as we have seen in the surgical video, or can be applied post-operatively as subconjunctival injections. The antimetabolite must be diffusely applied to the episclera after creation of the partial thickness scleral flap, but before paracentesis and removal of the corneoscleral block. So this diffuse application is very important, as has been shown in the surgical video, and as we have mentioned, antimetabolites must be applied before intraocular space is entered. The antimetabolite should be applied under both the scleral and the conjunctival flaps, and in this location MMC soaked sponges are kept for 3 minutes, and when using 5-fluorouracil the sponges are kept for 5 minutes. The higher the concentration applied, the more is the IOP lowering effect, but the incidence of hypotony also increases. So the concentration of the applied antimetabolite can be titrated depending on the underlying cause of glaucoma as well as other ocular issues such as prior conjunctival surgery. As we have watched in the video, after applying the sponges in the subconjunctival space, the margin of the conjunctival flap is pulled towards the conjunctival incision, taking care that the margin of the conjunctival flap does not touch the sponges, because that can inhibit the healing response of the margin of the conjunctival flap, which is the only tissue which should heal adequately with scarring in order to prevent Bleb leaks. The sponges are then removed and the exposed area is flushed with 20 to 30 ml of irrigating fluid, as we have seen in the surgical video. When application of antimetabolites is planned, certain intraoperative measures should be taken to reduce the incidence of thin cystic avascular blebs, which have a high incidence of hypotony and endophthalmitis. These measures include a fornix-based conjunctival flap, which promotes the formation of a diffuse bleb, a larger scleral flap, which can more effectively occlude the sclerostomy opening, and larger area of application of the antimetabolite so that we don't get a localized cystic bleb, and secure closure of both the sclera and the conjunctival incisions. When antimetabolites have been used intraoperatively, post-operatively suture release for raised intraocular pressure should be done later, and instead in the early post-operative period, if the intraocular pressure rises, digital massage or transconjunctival suture adjustments can be done. We'll be discussing these techniques in the next session on complications of trabeculectomy. Instead of or in addition to intraoperative application of antimetabolites, antimetabolites can also be administered post-operatively with subconjunctival injections, and both 5-fluorouracil and mitomycin C can be applied. And usually 5-fluorouracil is selected for this mode of administration and is injected subconjunctivally at a site away from the bleb. And it has been observed that more than 5 injections of 5-fluorouracil are usually required for long-term success of surgery if intraoperative antimetabolites have not been used. Mitomycin can also be administered subconjunctivally post-operatively but is associated with a higher risk. But this mode of application of mitomycin C has been described along with needling, which we will discuss in the next session. And when single intraoperative application of mitomycin C was compared with multiple post-operative injections of 5-fluorouracil, intraocular pressure was found to be significantly lower with mitomycin C 1 year after trabeculectomy, with lower risk of keratopathy but with a higher incidence of thin avascular bleb, which may lead to an increased risk of hypotony, bleb leaks, and endophthalmitis. And one of the protocols available for describing the indications and their required dosage of antimetabolites is the Moore-Flow regimen or the Moore-Fields-Florida regimen. And they have described the indications as those with a high risk of trabeculectomy failure, intermediate risk of trabeculectomy failure, and low risk of trabeculectomy failure. In patients with high risk of trabeculectomy failure, the Moore-Flow regimen recommends application of 0.5 mg per ml mitomycin C for 3 minutes or to consider tube shunt surgery, and these include previously failed trabeculectomy, previous cataract surgery through scleroconjunctival incisions, neovascular glaucoma, conjunctival scarring, conjunctival inflammation, uveitis patients, young patients, and patients with aphakia. Patients with intermediate risk of trabeculectomy failure in whom Moore-Flow regimen recommends application of mitomycin C 0.3 mg ml for 3 minutes or application of 5-fluorouracil 50 mg per ml for 5 minutes include patients with previous clear corneal uneventful cataract surgery, patients with previous conjunctival surgeries, patients undergoing planned combined glaucoma and cataract surgery, and patients who have been exposed to chronic application of anti-glaucoma medication over years. Low-risk patients who do not require antimetabolites include patients who have been exposed to anti-glaucoma medications for a short duration and older adults. And other than 5-fluorouracil and mitomycin C, many other agents are being evaluated as antifibrotics, among which we have anti-VEGF agents also. Ologen is another adjunct which can be used with trabeculectomy, and it is a biodegradable porcine collagen matrix as seen here in this photograph. It is placed over the scleral flap and is covered with the conjunctival flap, and mechanism of action of Ologen implant is twofold. Irregular spaces within the matrix of the implant sequester fibroblasts, preventing formation of a continuous fibrous scaffold, and the implant also maintains separation between conjunctiva and sclera, preventing adhesion between these two tissues. However, Ologen implant may interfere with post-operative suture management, and Ologen implant is known to degrade within 5 months. A modified form of trabeculectomy can be done with an express shunt, and in this technique, instead of removing a corneoscleral block of tissue, the express shunt is directly introduced into the anterior chamber under the scleral flap, and in this technique, iridectomy is not required. To recap the salient points, trabeculectomy is still considered the gold standard surgical treatment for glaucoma, in which a fistula created under a partial thickness scleral flap drains aqueous humor directly from the anterior chamber to the subconjunctival space. Indications of trabeculectomy are progression of glaucoma despite maximally tolerated medical or laser therapy, very high initial intraocular pressure with or without visual field loss, or very advanced visual field defect with a low IOP which may not respond further to medical or laser therapy. Trabeculectomy has a significant failure rate in neovascular glaucoma, uveitic glaucoma, conjunctival scarring, prior failed trabeculectomy, younger patients, and patients who have undergone cataract or any other intraocular procedure through a conjunctival incision. Pre-operative considerations include selecting the site for the fistula in the superior portion of the sclera, avoiding areas of conjunctival scarring, scleral thinning, peripheral anterior synechia, and peripheral iridotomy. Preoperative control of ocular comorbidities such as neovascularization, uveitis, blepharitis, conjunctivitis, and lag ophthalmos, whether patient is on anticoagulant or antiplatelet therapy, and whether patient will be able to follow post-operative instructions following surgery. Immediately prior to surgery, blood pressure and intraocular pressure are checked. Trabeculectomy is usually done under local anesthesia. Steps of the surgery include conjunctival flap creation, partial thickness scleral flap creation, excision of corneoscleral block of tissue, peripheral iridectomy, and suturing of the scleral flap and then the conjunctival flap. Adequate but not excessive drainage of aqueous humor through the scleral flap margins and adequate seal of the conjunctival incision with Bleb formation should be confirmed at the end of the surgery. Most important factor which predicts long-term success of surgery is the presence of a formed Bleb in the early post-operative period. Functional blebs appear elevated, avascular, and with microcysts in the conjunctival epithelium and can be either diffuse or circumscribed. Non-functional blebs can be either flat or encapsulated in appearance. Antifibrotic agents are used as adjuncts to trabeculectomy. They improve aqueous outflow but also increase the risk of hypotony, Bleb leak, and endophthalmitis. They are used in situations where the risk of trabeculectomy failure is higher. The agents used include mitomycin C and 5-fluorouracil. They are usually administered subconjunctivally, either intraoperatively before entering the anterior chamber or post-operatively as subconjunctival injections away from the Bleb site. When using antifibrotics, a more secure closure of scleral and conjunctival flaps are indicated. Thank you for listening.